Hi, and welcome to another Lunch and Learn. It's August 26th, I think. I'm Dr. Kara Pepper, an internist in Atlanta, Georgia. Today, I want to talk about making the most of your physical, understanding what a physical is and is not in our current day and age in our healthcare system, and how you can advocate for the tests that you need and deserve as you're aging. Like I mentioned, I'm in Atlanta. I've been practicing since my 21st year. I help physicians build solo practices, but importantly, I love taking care of adults 18 and over, especially folks who want time and space with their physician, and especially folks who deal with silent illness. A reminder, I am a doctor, not your doctor. And if you have any other questions, feel free to ask your doctor specifically. Um, as I do these lunch and learns, you'll see on this channel, I'm always open to topics. If you want to send me a message, feel free to do so. This is the QR code to reach me at my website, sign up for the email list, and schedule an appointment if you'd like. I'm going to open this document while we're talking. So a physical, as we traditionally know it, historically, decades ago, people would come in for what we in the medical world would call a Cadillac physical, meaning it's time blocked on the physician schedule. So we have time to sit down with our patients, really dig into what's going on with them, update all of their screenings, do labs, EKGs, chest x-rays, all of these things. And as the importance of evidence-based medicine grew, there are guidelines that would have suggested perhaps all those things that we were doing was not driven by evidence. Of course, we don't want to overbill patients for services they don't really need. But honestly, from an insurance-based standpoint, our American healthcare system is designed to make money for insurance companies. And so as time went on, the tests that insurance were willing to cover became less and less. So I think most insurance plans still offer one routine physical a year, either for free or for a very discounted copay. And so many people show up at this visit saying, I want to get all this stuff done, and are met with frustration because they either get a bill for testing that was ordered, or the physician says, I can do this small piece of what you want to do, but I need you to come back again for a follow-up visit to address your other concerns, which disjoints care. Believe me, physicians would love to be able to take care of everything all in one visit if we can, but in our current system, that is not always possible. A note for Medicare patients, what Medicare deems as a routine wellness exam has nothing to do with laying hands on a patient. It is a list of 30 questions that looks at lifestyle, memory loss, fall risk, alcohol use, some things that are relevant to general wellness. And that is it. That is what is covered under that. Not an exam, not labs, nothing else. So it is real that our insurance companies are practicing medicine and dictating what we can and cannot do in terms of care. So where does that leave us? And by us, I mean us patients, I'm a patient too, consuming healthcare, and us as your clinician saying, hey, I want to provide you with the care that you deserve. That is the point of today. So I want to give you a list of what I think about, pull back the curtain. What do I think about when a patient comes in every visit, especially their physical, to say, are they doing the things that need to get done in terms of routine screening? And I have a document that will be linked in the show notes. But I'm going to just scroll through it so you kind of know what I think about as I go through. Not recording. Hang on. Share. There we go. Share this thing. Okay, here we go. You are here live and you can't see this document called Checklist for Annual Physicals. Please just send me a message. All right. So I put this together for y'all. And so when someone comes in and they have time to sit down and talk, what I'm thinking about is globally, how is this person doing? What is their general sense of wellness? What are their mental, emotional, physical, spiritual, psychological stressors and wellness? How would they describe that? And what are their goals for this next year? I could have this amazing list of tests that I think that the patients need, but if your primary concern is, hey, I'm going through a divorce, like that is the primary issue that's impacting your overall wellness. So understanding what is going on with a patient is the most important thing. So we talk about lifestyle. How are you sleeping? How are you eating? How are you escaping reality and medicating stress? Are there any substances in the background? I talk about mood. And then we talk about just general behavior things, smoking cessation, alcohol cessation, etc. How are you doing as a human? In terms of the testing, and this is the part where I think patients should know what needs to be done so that they can, even like a checklist, make sure these things are being taken care of every year. So a basic risk assessment for cardiovascular health. Cardiovascular disease is the #1 killer of Americans. So what are the things that I think about that increase your risk of having a heart attack long-term? Risk factors would be age for women over 50 and for men over 45. So we can lie about our age, but we can't change it. And family history. Did you have a family member die at a young age from coronary disease? So those two non-modifiable risk factors are in the back of my mind. But the things that we do have control over or can manage would be blood pressure. So you need a blood pressure check, a cholesterol panel, or lipid panel, as some folks call it, assessment for diabetes, which is blood glucose or a hemoglobin A1C. So a glucose is literally like check your blood glucose either with a finger stick or blood. That tells you at this exact moment in time, how's my sugar doing? A hemoglobin A1C is like frosting of the red blood cells. It tells you how much sugar is stuck to the red blood cells. Red cells live for 100 days, so it gives you a 3-month average of how your sugars are doing. It's a basic screening test for diabetes. So those 3 risk factors, in addition to whether or not the person smokes, we talk about those things. For folks over 45, there is a test called the coronary calcium score that looks for calcified plaque in your heart arteries. So if you have calcified plaque at any age, that's a sign that there's been ongoing inflammation in the blood vessels and needs to be addressed. Here in Atlanta, it's $100 out of pocket to have that test done. It's not covered by insurance, but it's a really affordable test that can get done. It's literally a CT scan of your chest. And then often people say, well, I need to get an electrocardiogram. Again, insurance does not cover EKGs without a diagnosis. So you would have to have an elevated risk or a risk factor. But often physicians may still consider getting one at the age of 40. You may still see physicians who are doing them every year, but the global evidence-based guidelines would not suggest doing them every year. So I'm looking to see, are there risk factors that increase people's risk for having a heart attack long-term? #1 killer of Americans. We need to make sure that we're keeping an eye on those things. Cancer. So in terms of cancer screenings, there are many tests that are available, and you're seeing a lot of stuff come into the commercial market with these huge panels of tumor markers. Again, insurance is not covering those, and there's not standardized evidence for those, but the ones that are at the bare minimum that you should definitely make sure you're getting would be for people with breast cancer screening. Reminder that 1 out of 100 breast cancer patients are men. So if men found a lump, it definitely deserves to be screened. So a mammogram, basically every year starting at 40 or 10 years prior to when a first-degree relative, parent, sibling, is diagnosed. The really broad guidelines would suggest every 2 years in your 40s and then every year at 50, but I think most clinicians are practicing once a year starting at 40. Ultrasounds are insufficient because they look at the difference between cystic and solid lesions. They don't look for microcalcifications. The amount of radiation that people get from mammograms is less than what we get just walking around on this planet as humans. So for folks who say, hey, I'm just worried about all the radiation I would get, just existing as a human is more radiation than getting a mammogram. So don't let that be a deterrent. And MRIs are certainly better at picking up breast cancer, but they're more expensive and they're not covered by insurance. They are covered for folks who are high risk, but not average risk. So mammogram once a year at 40 is what I recommend. Cervical cancer screening, which looks for cancer of the cervix, pap smears with HPV testing. HPV is the virus that causes cervical cancer every 2 years in your 20s, and then every 3 to 5 years after 30 if you do not have HPV and you've had 3 normal paps in a row. We stop at 65, and frankly, there's nothing magic about being 65. It's because Medicare for a long time didn't cover routine pap smears. And so frankly, if you've made it to 65 without HPV and you have normal pap smears, the chances of getting cervical cancer are very small. So generally people will stop at 65, but you can continue past then if you want to. For men, the current guidelines for prostate cancer screening is basically talk to your doctor about prostate cancer screening. In other words, it's a controversial test. There are people who feel very strongly that everyone should get a PSA and that no one should get a PSA. I will say, globally speaking, most people start checking once a year at 50, although you'll see exceptions to that, and there's data for why you should not check or should check. But the conversation should happen between you and your doctor. Do you think I should get a PSA based on my personal risk, and et cetera? And then testicular cancer, Lance Armstrong was the kind of prototype for that. It's a young guy's disease, typically less than 30 years old, we'll see for patients. So we do an annual exam to look for lumps or bumps. If you found anything on your testicles, then that would be a reason to get a testicular ultrasound. So these are the, gender stereotyped cancer screenings that I recommend for patients. And then for everyone, colon cancer, we're seeing younger and younger. So instead of 50, we're now starting at 45 or 10 years prior to when a first degree relative was diagnosed, whichever comes first. I still recommend a colonoscopy where they go inside and look for colon cancer. And if everything is clear and they say 10 years from now is fine, that means that you're a low risk kind of person. But if they're finding polyps on that very first scan, if we leave those unattended, their chances of turning into cancer at years 7 to 10 are much higher. So I recommend everyone start with a colonoscopy so we know what's there. There are other tests like the FIT test or the Cologuard, which is a stool test that looks for abnormal DNA suggestive of colon cancer. It is just as good as a colonoscopy at finding cancer, but it doesn't do the preventative part that a colonoscopy would do. In other words, looking, seeing polyps and removing them. A stool test is not going to do that. So I love Cologuards for people who can't have a colonoscopy, can't afford to have a colonoscopy, can't have transportation for a colonoscopy, are terrified of anesthesia. But all things considered equal, I prefer colonoscopy for younger folks so we know what your risk is before we start screening. And then lastly, you can screen for lung cancer with a low-dose CT scan, low-dose radiation CT scan for adults over 50 with more than 20 years of smoking. Or folks who've quit within the past 15 years. It's a CT scan of your chest that will look for lung cancer. So it's covered by insurance typically. Here in Atlanta market, last I checked, it was like in the 130 to 150 range without insurance. So there's a scan available for that. So these are the very basic things I recommend for everyone. So if you are showing up to see your doctor for your routine physical, they should be able to offer you these screening tests. But if you're someone who may not be going frequently or you've changed docs, like you can know in the back of your mind, hey, it's been more than a year since my last mammogram. Even though I'm showing up for a sinus infection, I'm allowed to say, hey, can I get my mammogram order while I'm here? All right, vaccines. This is the recommended vaccine schedule for adults. Again, I don't take care of kids, so I'm not going to get into that part of things. COVID-19, clearly there's lots of big feelings about the COVID vaccine. The initial point of the vaccine was that it reduced your risk of having hospitalizations from COVID by about half. So for high risk people, either folks over the age of 60 or for people who are immune suppressed or other high risk conditions, it would reduce people's risk of being in the hospital. The more current data, and for me, the more compelling data for average risk adults is it reduces your risk of viral shedding. So you're less likely to get other people sick, reduces the length of time that you have an illness with COVID, and it reduces your risk for long COVID. And that is really what I'm seeing a ton of in my practice. And so for me, an average risk adult, it's why I continue to get vaccinated because I don't want to get my patients sick. I don't want to have to deal with long COVID. So COVID vaccines you could consider once a year. Same with flu shots. They reduce your risk of having, severe influenza by, on a good year, like 50 to 60%. So it's not perfect. But it also can decrease viral shedding. And so for me, that's the compelling reason why I get them to keep my patients well. Tetanus and whooping cough is a combined vaccine, the Tdap. They give it to every consenting woman in her third trimester of pregnancy. So most adult women who've had children have been offered this vaccine. If you are a family member of someone who's pregnant, you may have been offered that. But if you haven't had no exposure to fetuses, then every 10 years is what we would recommend for the tetanus vaccine, and then once for the pertussis vaccine. Shingles is available, 2-shot series for folks 50 and older. Pneumonia, we now start at 50. It's 1 shot at 50, and then again every 5 years starting at 65. HPV, I mentioned back with the cervical cancer screening, when people say, why would I give people vaccines? This is a reason. HPV vaccine prevents cancer. And so it's now approved for people up to the age of 45. So if you've not been vaccinated for HPV, I certainly recommend that. And then for folks who are at risk for hepatitis, like healthcare workers, hepatitis A and B, or if you're traveling to an endemic area, you can do hepatitis. RSV, we do at 60, and then MMR, they're actually now with the measles on the rise, a booster at age 60 is a reasonable test. or you can test your blood to see if you carry antibodies. So as you look at that list, you can think about where do you fit in the age spectrum, what may you be considered for, and then asking your doc for those. If you do not have a doctor, you can get these vaccines at your local pharmacy. You don't actually have to go to a doctor's office anymore, so you can stay up to date with your vaccines even if you don't have a PCP. All right, so we talked about heart stuff, talked about cancer stuff, talked about vaccine stuff. So let's talk about bone stuff. So interestingly, as someone who takes care of most of my practice is women, our current guidelines for bone density screening say check a bone density once at age 65. Now, that is way too late, in my opinion, because the biggest drops we have in bone density are as we go through menopause, which is much closer to 50. So I would want to know if I were in osteoporosis instead of waiting an additional 15 years to get screened. So generally speaking, you'll see folks get screened at 50 or once they go through menopause. If there are risk factors, like in my population of patients who largely have eating disorders, I will screen them much earlier because that's a risk factor for bone loss. A bone density test is kind of like an X-ray. It looks at the lower part of your spine, your lumbar spine, and then the top part of your thigh bones where it enters your pelvis, the femur, the femoral neck. So it checks those two spots for bone density compared to other people your age and gives you a reading. It is actually recommended for men as well over the age of 70 or younger if there's risk factors. Okay, so you can have that to your checklist. And then cognitive health. Of course, many folks who come to see me are worried about their brain health. They want to make sure that they're living a health span, not just a lifespan. So looking at cognition, there's formal screening tests that we do to screen for dementia. Honestly, that test alone usually takes about 20 minutes. And so often a lot of docs are not doing that as part of their routine physicals, but you can set up an appointment for an assessment related to that. And I think that everyone, and Medicare would suggest this as well, everyone over the age of 65 should be screened regularly for that. And then lastly, the kind of blood tests that I often order, the standard panels that insurance still will largely cover is what we call a metabolic panel, looks at kidneys, liver, electrolytes, a complete blood count with differential, that's white cells and red cells and platelets. I usually check a thyroid test. You may see some docs not doing that. Cholesterol, which I mentioned earlier, and sugars. Those are the big ones. In addition to that, it's also very reasonable to look at vitamin D levels, which many people are low. If you have new sexual partners, doing a sexual transmitted infection screening. So talking to your doctor about sexual behaviors is important to protect you. And then hepatitis C screening, everyone born between 45 and 65, it's recommended to at least have one screening once. And then HIV, which I consider part of the STIs. So there's other labs that you can have ordered there too. So as you look at yourself this year, what do you do for? Is there anything that has not been done? Is there anything that you need to have done? And you can reach out to your doc. A reminder that even me telling you about these tests has now taken me about 20 minutes. So you can imagine in the work of meeting with your doctor with very limited time, if you're in a commercial healthcare model, this is a lot to cover. So don't feel that you need to cover all of it in one whole visit. You can think about it, visit to visit as you're going in to be seen. What do I need to get? Oh, I'm due for my mammogram. Let me get that in this next visit. So having a way to just stay on top of those things once a year. I recommend sending yourself reminders in the future. Hey, 2 years from now, I'll be 45 and I need to have my colonoscopy. I'll send myself a reminder for that. Or I had my mammogram in March. I'm going to send myself a reminder next March to not forget. And so you can stay on your health, your health as well. So I hope that this has been helpful so you understand what you can be in charge of in terms of staying healthy and doing the screening tests that you need. And I'm here if you have any questions or concerns. Thanks for listening.